It's my pleasure to introduce to you Hunter Kellett. Hunter, do you want to come on up here? So Hunter is our keynote speaker. And let me just... So Hunter is... He's the healthcare director of payer reform at Arnold Ventures. He develops and oversees strategic investments to help lower healthcare spending. Prior to joining Arnold Ventures, he worked as a senior analyst on federal healthcare programs for the White House Office of Management and Budget. So he's a lot of experience in the healthcare space. We're just so pleased that he's been, I don't know, he's just really nice to work with and very supportive of our work. So my pleasure to introduce to you Hunter Kellett.
Good morning, everyone. So this is actually my first visit to the state of Indiana, but I talk a lot about Indiana in my work at Arnold Ventures. See, Indiana, and it sounds like folks know this, is actually a leader on healthcare prices when you look at both the state and federal level, and it really is no surprise that Indiana is where that RAND hospital study originated. When employers started asking questions about why they had to pay so much for healthcare each and every year. That, of course, led to an effort to discover what are the prices. And then once you knew what the prices were, how do those prices compare to other states? How does Indiana compare to its neighbors? And that has begun a conversation here in Indiana involving policymakers who are now demanding solutions from industry, who feel like this path is unaffordable and not sustainable. Even at the federal level, some of the members of Congress from Indiana have introduced some of the most aggressive solutions for addressing hospital prices, and that includes capping hospital prices. I'm actually from California, and you may not think there's a lot in common between California and Indiana. Very different climate. Why is it so cold? Very different geography, very different political leanings, but both states, very different, very, I went through very diverse, California as well, states are going through the same issue. They're dealing with large, dominant, consolidated health systems that are charging prices sometimes 3 to 4 times what Medicare would pay for the same service. And we now know who those systems are. We can name them. So my understanding from my friends in Indiana it's Parkview, it's IU Health, it's Ascension. In California, it's Sutter. Where I grew up in San Diego, it's Scripps. I live in Northern Virginia now, it's Inova. In Colorado, it's the University of Colorado, UC Health. In Massachusetts, it's Mass General Brigham. It's these large multi-state systems like HCA. So we can go across each and every state in this nation and name the large dominant health systems that are driving up the cost of healthcare. And I want to be clear, I'm not talking about rural hospitals, and I'm not talking about safety net hospitals. We should be having a very different policy conversation about the role of those essential providers and their communities, and what policy solutions should be on the state. I am talking about those large systems, I'll keep saying the same words over and over, large dominant systems charging 3 to 4 times what Medicare would pay. And these systems affect all of us. So for you purchasers in the room, this is a tax on your business. Essentially, you have to buy your employees a new car each and every year to cover the cost of healthcare. And it affects your business decisions. It affects who you can hire. Do you hire a high wage, low wage worker? Can you have them work full-time, part-time? Can you even offer health insurance coverage to them? It's your profit that you could be reinvesting in your business that goes to healthcare. For insurers in the room, it's time to start talking about what options should be on the table. How do we need to change the market? What policy changes do we need to be discussing? Because the status quo, it's not working. And even for physicians or nurses, those that work in these large systems, not only does it impact your patients' ability to afford or even access the care that they may need, it can also impact working conditions. And we've seen these large consolidated health systems not only use their market power to raise prices, they can use that market power to lower wages, or change benefits, or put in certain non-compete clauses in your contract. If there's only one employer in a region, you don't really have a lot of leverage, even if you are, for example, a physician. And lastly, consumers. 1 in 10 consumers, people in America, have medical debt. And every one of us here in this room are consumers. And if you get your insurance through your employer, there are trade-offs being made. We've looked over the past 2 decades, we're seeing increases in deductibles, increases in premiums, increases in cost sharing, and wages have not grown nearly at the same rate. And so there's a trade-off between our compensation and how much employers are choosing and having, they really don't have a choice, how much employers are having to spend year after year on healthcare. So today you're going to learn a lot about healthcare prices and hospital transparency. You're going to see new tools available. It's going to give you new insights to what are the prices in one state versus another state, how do prices vary within a state. You'll see how prices vary within a metropolitan area, and you might even see how prices vary within the same hospital system. Essentially, these prices don't reflect a functioning market. We're going to talk a lot about hospital costs. Do hospital costs explain these prices? And the short answer is no. For a lot of these systems, the prices they're charging far exceed their cost, or essentially what their break even would be, what they would need to charge to cover their costs. Does quality explain these prices? No. The short answer is no. And so my question for you all in the room is to think about, how are you going to use these tools? I'm sure you're going to think about how you can be a smarter purchaser, how maybe you'll have more leverage at the negotiating table. But I would encourage you to also think about how you can use these tools to educate others, to educate your policymakers, to educate your colleagues, so we can start to create an environment, we can start to create this voice of people talking about prices. So what I'm going to talk about today is a little bit about Arnold Ventures, who we are, how we think about this issue, and then I'm going to go through what I think are the policies that should be on the table. So Arnold Ventures, we're a philanthropy of John and Laura Arnold out of Houston, Texas. And their philanthropy is dedicated to addressing some of the nation's toughest problems, like criminal justice reform, like higher education reform, like public finance, and of course, healthcare. And our healthcare strategy is focused on reducing spending for 3 key groups. And it's important to keep those 3 groups in mind from our perspective to ensure we're not just moving money around in the system, we actually want to reduce spending. And so those 3 key groups are patient, employers, and taxpayers. And when I talk about patients, I mean deductibles, out-of-pocket spending, and premiums. We don't want solutions that reduce the price at the prescription or the pharmacy counter and then jack up premiums. When I'm talking about employers, I mean employers are the largest financiers of commercial health insurance in this country, and so we also want to reduce the amount that they have to spend year after year, and same with taxpayers. Taxpayers directly and indirectly subsidize the cost of healthcare. So any solution that I'm going to talk about today, at least from our perspective, is aimed at reducing spending for all 3 groups, and in a way that maintains high quality care. And I think when you look at some of the tools and you can see how these prices far exceed costs, we do think we can reduce prices while still maintaining access to a lot of these high quality facilities. So I just put up here so you can get a sense of what other areas in healthcare we're focused on. We try to approach healthcare spending from all different angles. So we have teams and grantees working on commercial sector prices, which is what I'm talking about today. drug pricing, FDA reform, clinical trials reform, a portfolio looking at utilization. If we're going to try and reduce prices, we also have to ensure that it doesn't lead to increased utilization. And so thinking about payment reform, thinking about putting Medicare on sound financial footing, Medicare sustainability. And lastly, care for complex populations. And we're talking about those small percentage of enrollees that are a high portion of spend. And maybe for this population, it's less about lowering spending and more about how to spend more efficiently. Next, I want to talk about our approach to creating change. And the reason that I do this is not only so you can understand how we got to where we are on this issue, but maybe as a framework that you all can use as well to think about hospital prices and how we go from just talking about and identifying the prices to what we're going to do about it. And so everything we do at Arnold Ventures begins with research and evidence. What does the research say? And it's pretty clear on this issue that it's prices, not utilization, driving up the cost of commercial health insurance. And so we ask, what's the drivers of that? What are some of the leading secondary questions related to that? Of course, for example, consolidation is a main driver of this. And so we fund a lot of research to build this evidence base and ultimately inform policy development. So once we've answered those questions, what are the policies that should be on the table? We have a number of grantees that work in this policy development space, including Nashville, who's going to talk later today. Once we know what policies should be on the table, then we engage in technical assistance and advocacy. We actually want to get those policies implemented. And so we have grantees providing technical assistance to a range of actors, including employers, consumers, and in particular policymakers, both state governors, legislatures, and even at the federal level. And then lastly, and maybe most importantly, and I'm going to come back to this throughout the remainder of my talk, is the visibility in communications. We have to create an environment where we can talk about prices so that it creates political windows and political opportunities for us to actually enact changes here and address prices. And I think a lot of what we're talking about today can help contribute to that environment. So the first sort of group of proposals of policies I'm going to talk about are transparency related. We do think there are opportunities to improve transparency. It does create that environment and raise awareness about high prices. And two tools that AV has invested in are going to be discussed today. The first is Nashville's hospital cost tool. And I would say for both of these tools, it was really important for us for you to get data where you could identify the specific hospital system, because we hear from our employer friends all the time how this data is critical for them. And so now you have it. You're gonna be able to see by specific hospital and system what prices are, what quality looks like, what do the costs look like. And so what are you going to do with these tools? How are you going to use them to improve your business? How can you also use them to create this environment I'm talking about? And really looking forward to Gloria, after me, rolling out her new tool that she's been working on. There are some other, I would call them relatively low-hanging fruit, but there's still battles to get these implemented, potential policies in the transparency space. And the first one are APCDs, or All Payers Claims Databases. At this point, I would say more than half of states have APCDs, but a lot of them have really funny rules. It says, the state is going to invest in building this wonderful tool, and then you can't use it to submit it to the RAND hospital study. You can't use it to inform policy. You can't use it to identify specific hospitals or insurers in the data. A lot of these restrictions really prevent it from being used for some of the best use cases. Once you have specific data on your state, then you can actually design policies that are specific to your state. And so, for example, when you look at Colorado, which has an APCD, they have used it for their out-of-network billing policy, because they can actually look and see, hey, what are out-of-network bills in our state? And if we want to enact a policy that's going to lower healthcare spending, where do we need to set the sort of benchmark for out-of-network bills? A lot of states can't do that. And so APCDs can be a really powerful tool if used the right way. Also, other plug, a lot of employers don't, or their TPAs don't submit to state APCDs. In some cases they can't, but if you're in a state that has a voluntary process for submitting, please submit your data. It's really critical for this sort of policy development. The next one I want to briefly mention is Nashvilly's model law on hospital system financial reporting. Yeah, the tool will get you a lot of the way you need to go. You'll understand the financial situation of hospitals in your state. But you need to think about policymakers. Almost every day, policymakers are hearing from providers who are in their districts saying, if you do not pass this policy, or if you do pass this policy, we will close and people will lose access. And so we need to provide more transparent data showing the financial situation of providers to empower policymakers also to be more aggressive on this issue. And so doing this at the state level can give you more timely data. Nashvilly's tool is phenomenal, but it uses CMS cost reports, and those take time for hospitals to submit. And there may be also other financial data that states could collect. And lastly, community benefit spending. So a lot of the hospitals we're talking about today are nonprofit, and they get a substantial tax benefit, and they also have requirements. And so what are they doing with this tax benefit? How are they helping their communities? States can measure this, can also put more requirements on it, but what I think you're going to find is that, and we've seen in some of the data done, or research done by some folks that are here at this conference, like GBI, that these nonprofits look the same as for-profits. They just get a tax benefit. In some cases, they even provide less. And so this can really bring attention to this issue, can change the mindset about what a nonprofit health system is, and also help create this environment. But from our perspective, transparency is not enough. We already know these systems. I named a number of them. In a lot of cases, we know their prices. And so we think we need to do more. And one of the reasons we think that is because of a study done by Johns Hopkins University that did look at where in the country do employers have sufficient market power where they could actually push back on these health systems and demand lower prices. So here's the map of their findings, summarizing their findings. White or lighter colored areas are areas of the country where employers do not have a lot of market power. And then you can see in the darker red areas of the country where they do. So I'll give you a second to look at it. See, the funny thing is, a lot of these red or dark areas, those are colleges and universities. And what do they typically have? They have health systems attached to them. Do we realistically think that these colleges and universities are going to be the ones that are going to aggressively demand lower prices? And so because of this, we think we need to be talking about more aggressive policy options. So the next bucket I'm going to talk about is focused on mitigating consolidation and improving market competition. The hospitals are already consolidated. Almost the entire country is highly consolidated, but maybe there are lines of business in your communities. Maybe you're in one of the lucky areas where this hasn't fully occurred yet. And so there are things you can do to prevent future consolidation and also limit the market power of these consolidated entities. And one of those is prohibiting anti-competitive contracting practices. And these have really been exposed through DOJ litigation that has brought attention to these provisions that large systems in North Carolina and California, for example, but also across the country are using. And they include things like preventing employers and third-party administrators or insurers from directing or incentivizing patients to use lower-cost facilities. So Nashville has a model law. There are 5 of them. Nevada passed bans on these last year. California is considering. A number of other states are considering as well. The other thing is enhancing state merger review policies. And so in the physician space, we've seen private equity come into markets and then slowly buy up all these small practices that never hit the merger review thresholds until suddenly you realize all the physicians in your market or in your state are owned by the same company. And so there are things states can do to lower the threshold, to require public disclosure, to give states time to review these mergers, to require information to be submitted, and to give the state authority to deny mergers that are going to increase prices. And we saw Oregon pass this last year, and they've now implemented this law, and other states are looking at the Oregon model. And then the last 2 I want to talk about are distortions in the market. And so these large consolidated health systems use this market power, and then we see these sort of funny market failures. And they're not really that funny because they result in a lot of costs and a lot of medical debt on consumers. And that includes surprise billing, which was largely addressed at the federal level, but there are exceptions, including ground ambulances, which are not subject to this. And everyone in this room should be on the lookout because states have some authority to undermine the federal law and pass their own laws that can be inflationary. And so we really need to make sure that providers are not using this opportunity to try to get higher out-of-network rates. The other one is site neutrality. We've seen for the past 2 decades, hospital systems gobble up physician practices, and then they can charge higher prices and add facility fees. And so that's another thing to consider. A number of states are looking at potentially using Medicare site neutrality laws and applying it to commercial market, and then also banning facility fees in certain cases. So I've said multiple times, the market is already consolidated. And yeah, these are some great policies you should have on the table. But if there's only one health system, if you truly have a monopoly and they're already charging prices that are 3 to 4 times what Medicare pays, we need to start talking about regulation. And so I've included a number of regulatory related policies. I would say they largely are from least aggressive to most aggressive. But for any of these, states can design them in a way that meets their needs, that also serves their other goals. And so the first one I want to mention are cost growth benchmarks. We've seen about roughly 10-ish states implement this model. And essentially what it does is it sets a target in their state. We do not want healthcare in our state to grow above X percentage. And then they measure, and they actually see, is healthcare growing against that? They can bring attention to those entities that are contributing to that growth. And we've seen this past year, Massachusetts, who was a leader in this model, actually take enforcement action against one of the large drivers in their state, which was Mass General Brigham. And then we're seeing other states take approaches where they're going to penalize systems that are making their state grow faster than this benchmark. The next one is insurance rate review. So state insurance commissioners have a lot of authority for the individual market, small group, and the fully insured market to approve rates. And so we've seen the states use this as a sort of leverage point. Rhode Island explicitly says in our rates, hospital prices will not grow higher than X percent. And over the past decade, it's been largely successful. And we've seen Delaware just recently take up that model. We've seen other states experiment with approaches as well. The next one I want to talk about is interjecting competition into the insurance market. And I'm sure everyone here has heard the term public option. It can mean a lot of things to a lot of different people. It's a very political term. But when we look at states that have actually enacted these public options, Colorado, Washington, Nevada, They look a lot less like a public option, like a public plan, and a lot more like a private plan. And essentially what they are regulated private plans. And these states have accepted in these plans have not been able to lower prices. And so they use their legislation to set price targets, to set premium reduction targets. And then these plans are required to offer products that pay those prices. And they use a variety of other state enforcement authorities, like the Department of Insurance Commissioners, for example, to ensure these actually happen. And then lastly, directly limiting prices. So we know that these are monopolies. We know that they're not going to regulate themselves. We know they already are charging 3 to 4. They're not just charging, they're getting paid 3 to 4 times what Medicare would pay. It's time to start talking about how we actually limit those excessive prices. And there are a lot of different options about how you could design this. So what we've seen in some of the legislation at the federal level is you could target it to specific markets. Is this market consolidated or not? If it is consolidated, then there's price limits. You could look at the distribution across your state. We're going to only focus on those hospitals that are in the top 25th percentile, and we're going to bring down their prices. So we think this should be on the table, and like I said, there's a lot of options here in how you could design it. So I just want to end here by sort of reemphasizing what I was talking about at the beginning. Yes, Indiana is a leader on hospital prices, but we are starting to see states across the country, different groups of people, employers, consumers, come together and start using the word prices, talking about the problem, and really like a wide variation and experiments in different policy approaches for what we're going to do about it. And so if you don't know about Dale Folwell in North Carolina, you should look him up. He's the Republican elected treasurer in North Carolina. And when he took over, he was ultimately financially responsible for the state employee plan in the state. And it faced a deficit. And I think they felt like in North Carolina, they were at this place where they could not raise deductibles anymore. They could not raise co-payments or premiums. They just felt like those enrollees were maxed out. I think probably a lot of people in this room probably feel that way, or online. And so they went to industry. They said, industry, what should we do about this? They asked the hospitals, insurers, physician groups, and they got almost no ideas. And so they then went to try to understand, well, what are the prices? What's the fee schedule that's being paid to these providers? Turns out they couldn't see it. It was proprietary. And so they got no ideas. They have no data to understand the drivers. And what he did is start something called the Clear Pricing Plan or project in the state. And he said, I'm going to pay providers based off a percentage of Medicare. And I'm going to be really transparent about it. And he saw all of the hospitals in the state band together and say, we're not going to participate. And so has begun a multi-year battle to try to bring clear pricing to the state. And he's raised a lot of questions. Let's talk about their community benefit spending. Let's talk about some of these anti-competitive contracting practices, for example. But I share that because this is really hard to do. This is not a one and done thing. This is not a one session issue. And it's going to take a lot more than just one state or one state here or there to really create this environment. We all need to work together. And so Indiana, yeah, you are a leader. And I really need you to help educate other states. Educate your neighbors. Educate your colleagues who work out of state. When you go to your association meetings, talk about prices. And in particular, please talk to your policymakers. Talk about the markets that you operate in. Talk about what it means for your business to pay these high prices. Because the only way we're going to make progress on this issue is if we all work together and we're all talking on the same message and sharing the same points. So that maybe in a couple of years, we won't be at a conference on transparency, right? We'll be at a conference talking about which solution are we pursuing, what we're going to do about it, or maybe even how the solutions have been working. So I want to end and thank Gloria, of course, and all the incredible work she does and her organization, and of course, a lot of you in the audience who've been working really hard on this issue. It's an absolute pleasure to be here. So thank you very much.